Hi, my name is Chris. I'm an anaesthetics trainee from South West London, and I'm also the chief investigator for the REPACC study, which is a national trainee-led research project investigating perioperative enhanced care services in the UK. So for some context, the UK surgical infrastructure is under mounting pressure from an escalating waitlist since the COVID pandemic. This has been compounded by a high rate of on-the-day surgical cancellation, with roughly 20,000 elective surgical cancellations happening across the UK every 3 months. Crucially, the requirement for an ICU bed in the post-operative period increases the likelihood of cancellation by nearly 3 times. So in response to this, the Royal College of Anaesthetists and the Faculty of Intensive Care Medicine have advocated for the development of enhanced care services in the UK to relieve pressure on critical care beds and hopefully prevent cancellation. Because the design of these services has largely been led by host institutions, little is known about the landscape of enhanced care in the UK currently. So we aim to describe the national picture of these facilities, define the population they serve, and assess the impact of their introduction on organisational outcomes. We recruited 110 centres across the UK, each providing survey data describing the local structure of enhanced care and patient-level data for all elective referrals to enhanced care and critical care over a 3-month period. We found that 63.6% of hospitals had an enhanced care facility, which is roughly a 7% increase since last surveyed in 2020. As you can see from the map on the right, uptake of this model of care has been relatively uniform across the UK. These facilities were generally 4-bedded, with nurses caring for 2 patients each, and were mostly capable of providing an intermediate level of clinical care. They employed variable admission criteria, and notably risk score-based admission was common. Of the scores used, SORT was most popular, and generally speaking, a predicted 30-day mortality of 1 to 5% was employed, in line with current guidance. There have been some notable changes since 2020, indicating significant internal development in already established facilities. For example, the number of facilities providing additional training to nurses before working in enhanced care has increased from 37 to 94%. Our patient-level data described 5,990 referrals to enhanced and critical care. We found enhanced care patients to be younger, with fewer comorbidities undergoing less complex surgery. Notably, the majority of our patients in our study were cared for in enhanced care, which indicates the shift in focus towards providing care for high-risk surgical patients in dedicated facilities as opposed to within critical care in the UK. In terms of outcomes, which are on the right, we found that enhanced care patients were less likely to be cancelled, had a shorter length of stay, and exhibited lower mortality at 6 months. These may reflect both operational efficiency of these facilities, but also the lower clinical acuity of enhanced care population, within which more favourable outcomes would be expected. Encouragingly, the trend towards reduced cancellation in enhanced care facilities when compared to critical care was observed in nearly all of the enrolled sites, which may represent better protections for these resources through practices like ring fencing. Overall, our results demonstrate the UK to have a mature enhanced care infrastructure that provides suitable alternatives to critical care for high-risk patients. These facilities may also be associated with certain organisational benefits. However, confirmation of this would require a global assessment of outcomes across all relevant clinical areas. Thank you very much for listening.